So I think we'll do a little talk about tissue integrity, and really in this lecture we talk about three things primarily. First and foremost, pressure injuries or pressure ulcers. Secondly, we talk a little bit about cellulitis, which really isn't a new concept for us because we've talked about infection in the past, and so we already have an idea of what infection really means. We're just going to look at it in, I guess, a different part of our body that is infected. And then lastly, we'll talk about what we call vascular ulcers, and that can include both venous stasis ulcers as well as like our arterial ulcers. When we talk about tissue integrity, of course, that's the priority concept. And anytime we have a problem or an alteration in the integrity of our skin, then there's opportunity for infection, of course, because we are kind of breaking through that immune protective barrier. And then pain is something that we have to consider as well. So when we talk about pressure ulcers, so our first concept here, pressure injuries, there's something going on, usually external, but can be internal issues that contribute to this as well, that's leading to a breakdown of the skin. And a lot of times we see this over areas that are bony prominences, and we think of things like our heels or like our hip bones, our bottom, maybe like the bony spinous processes there on our back, maybe shoulder blades, maybe the back of our head. These bony areas, elbows, I guess would be another one, are particularly prone because they also come into contact with us with a surface, and so we have those opposing forces, I guess, if you will, of that bony prominence that can promote like internal kind of rubbing of the tissue combined with the external force of the surface, and we're starting to see those two things oppose, and it can lead to wearing down of that particular area of tissue. So we move, we kind of slide, tissue starts to slide over bony prominences, and ultimately it can compress like little blood vessels inside of there, the area. It can cause damage, cellular destruction of those tissues underneath of there. And so just like you can see in this image on this particular slide, we're really focusing here with this image those concepts of friction and shearing, where you have that movement or sliding of the skin, not only against the surface but also against internal structures, kind of having opposing movements that leads to breakdown of that particular area. So when we're looking at an assessment of a patient, our skin assessment covers our whole body, really. So there's lots of places that we're looking, and we're going to focus on those areas that are more likely to develop damage because of these forces of friction and shearing, or those particular locations that are more likely to develop pressure injury, those bony prominences that come into contact for long periods of time with a surface. Lots of things can kind of factor into that, and we'll kind of talk about that when we get to the Braden scale. Really, the best thing that we can do to promote good, healthy tissue integrity is to recognize the patient that's at risk and the location on the patient's body that is at risk, and really start to uh, intervene early so that injury never even really occurs at all. Pressure injuries can not only lead to infection and discomfort, pain for the patient, but they can take a really long time to heal. Oftentimes, patients have multiple underlying medical conditions that can exacerbate a patient's ability to heal. They may take certain types of medications that can interfere with the body's ability to heal appropriately. So those are kinds of things that we need to keep in mind when we're trying to determine whether or not a patient is at risks. And then, of course, anytime we do identify some type of injury on the skin, the sooner we can implement those interventions to prevent it from getting worse, then the better off the patient's going to be. Some of the other risk factors, besides comorbidities, I kind of mentioned that just previously, is how well a patient is able to move, especially independently. When a patient has very limited mobility, they are not able to make those subtle, albeit important, shifts in pressure areas off of those bony prominences, those injury prone locations. So if you think about a patient who is very weakened because of some kind of illness, maybe because of problems that they've developed as they've gotten older, other comorbidities, if they're feeling uncomfortable in a particular position, they're not able to shift that weight off of that area of pressure. So that's one thing we need to consider. Another consideration is moisture. When we have patients who have excessive moisture, it creates this environment where skin is more prone to break down, not only from pressure, but also other things like what we might call incontinent associated dermatitis. So if you've ever had like I don't know, you've been outside and you've kind of been sweating a lot, right? That would be an example of excessive moisture, and maybe some of the clothing that you were wearing kind of was irritating, kind of causing some friction or rubbing on that sweaty surface. It could kind of make that area of the skin raw. And the same is true for patients who experience incontinence. It just creates that environment where skin is more likely to break down. And with incontinence of whether it be urine or feces, that's not just, benign water. Those materials can contain varying amounts of acid, like they can have different pH that can just exacerbate that irritation of the skin, can really cause a lot of discomfort for the patient. Again, if someone has some sort of comorbidity that leads to delayed healing or altered perfusion to the particular skin, because you remember, all of our body, all of our organs, including our skin, requires nutrients and oxygenation and to get to the area so that it can perform whatever cellular function that organ or tissue is meant to perform. And it also needs to be able to get rid of any type of waste that it creates as it's performing its function. And so if we have alteration in perfusion or blood flow to the skin, that can be something that increases risk. With diabetes, especially over long periods of time, we can have little microvascular changes. Elevated blood glucose can lead to delayed wound healing. So they just are particularly at risk. for skin problems like skin breakdown and skin healing, wound healing, that kind of thing. Another thing with diabetes is because of some of those changes that can occur over time because of chronically elevated or uncontrolled even blood glucose, is they can develop something called peripheral neuropathy. And with that condition, it oftentimes will affect the feet. I mean, it can affect your hands, like your fingers and stuff as well, but oftentimes it affects the feet. And what we see happen in patients with peripheral neuropathy because of diabetes or other things, they may sustain an injury to their feet, but they don't feel it because of this neuropathy, this altered sensation to their extremity. And so by the time they realize that they even have a wound, it may be, uh, relatively bad. And you couple that with, those other considerations with that disease process, and it's going to then take longer for that tissue to heal. Nutrition is important for lots of things. Skin integrity, especially if a patient has poor nutrition, it's just overall going to affect their skin integrity as well as other things. And when we think about the patient who maybe has cognitive problems or sensory perception, that could be peripheral neuropathy, could be a sensory perception issue, but they're not able to feel the need to change positions or move. Maybe they have some paralysis to a particular location. But also with cognitive problems, perhaps a person doesn't maybe recognize that they need to seek care for an injury, or perhaps they don't have the mental capacity to recognize that they have some hygiene issues that can contribute to skin breakdown and irritation of the skin. So some risk factors that we can kind of see here give us an idea of if we see these things in our patients, then we need to be hyper vigilant, if that's a word. Maybe it's just vigilant, in checking the skin on individuals that kind of fit in one of these kinds of categories, or maybe they have multiple categories, which is oftentimes the case. Patients who are in an acute care setting, or even if we consider long-term care patients, they are often have decreased mobility just because of their severity of illness or their chronic illness, if we're thinking like long-term care, and so they're going to need some assistance with some of these risk factors and kind of closing that gap of the risk factor and what's best for their skin. So if I'm thinking of the patient who maybe is bedridden, that can't turn on their own, they're too weak, then we would consider for that person moving for them. And this is an example of when you are turning patients. We turn patients to relieve pressure off of pressure points because they're not able to do that on their own for whatever reason. Or if somebody is unable to ambulate, maybe for some reason their legs don't function, they can't walk, and they are sitting in a chair. It's good that they're in a chair, but even in that same position, we are increasing the amount of pressure that's on certain places, like the kind of our sits bones or the ischium, I think is what they technically are called. We need to do those things for the patient. So, I guess the way that I like to think of it as is once I recognize a risk factor, some kind of issue that my patient is experiencing, my interventions kind of work to close that gap. So as the nurse, I'm sort of doing those things with the patient or for the patient because they're unable to do that for themselves, like with incontinence, right? If someone is incontinent, with the patient, for the patient, I am making sure that their skin is staying clean and dry. If they're unable to get adequate nutrition for whatever reason, I'm implementing things to try to address that issue because the patient's not able to meet that need on their own. I think that's really a lot of what nursing is. Um, it is kind of meeting the patient where they are, and then working to either with the patient or doing things for the patient to get them to where they need to be for optimal health. Um, this kind of terminology here that you're looking at, compromised tissue integrity due to vascular insufficiency and trauma, potential for infection due to insufficient wound management, this type of language is very akin to what you would see if we were writing a nursing diagnosis. I don't think these are official nursing diagnoses, but basically when we've identified a problem on our patient, in this instance compromised tissue integrity, we've come to that conclusion because we've looked at all of our assessment factors, whether that be risk factors, or if we've combined that with physical assessment, things that we know about their history, things like that. That's what this kind of language is here that you're seeing on this slide. When our goal with pressure injuries is we want to make it better, right? We want the pressure injury or the tissue injury not to get any worse, and we want to make it better. There are many things that we can do to help promote that. You can see a list of things here. It's not just a one size fits all for every patient. We have to consider the individual risks that are leading to the patient experiencing a breakdown or an alteration in their tissue integrity. Much of what we do for pressure injury, whether it be prevention or treatment, is really a lot of non-surgical management. It includes things like nutrition and mobility and keeping skin dry and keeping blood flowing and treating underlying medical problems, making sure the patient has good nutrition, that kind of thing. Sometimes you'll find that when a patient does have a pressure injury or a wound that's not really responding perhaps to some of our non-surgical interventions, then they may require surgery to help aid the healing of that wound. When we have a wound or a sore, I guess, if you will, there's a certain progression of tissue rebuilding that we expect to see, and a variety of different things can go wrong during that healing process. And so sometimes we have to do some kind of surgical management. If tissue is not healthy and viable, we have what's called maybe a necrotic tissue. That dead tissue, if it's left within that wound, is going to impede the growth of healthy tissue at that point. And so we may have to go in and remove that. So that can be done multiple ways. It doesn't always have to be surgical. We call that debridement, or that essentially that means the removal of that non-viable tissue. So we can do a surgical debridement. Oftentimes that's done, by a provider, but there are other ways that we can get rid of that non-viable tissue. There are certain types of like enzymatic debridement, like like a medication, in other words, that you might place inside that wound bed to get rid of that non-viable tissue. We can do like a mechanical type of debridement that would remove that dead tissue mechanically. Oftentimes, this is the idea behind what we call a wet to dry dressing, because when we place that moistened gauze, I guess would be an example of something you'd place inside the wound bed, and cover it with dry dressings and allow that to kind of dry up. When you remove that dressing, it can then also kind of pull out. Sounds traumatic. I guess it kind of is traumatic. Can kind of pull out that dead tissue. We do have to be careful with those types of debridement therapies like enzymatic debridement or mechanical debridement, simply because we may not pull out only non-viable tissue. Sometimes we can also damage good healthy tissue, so you have to be careful with that. Other times we might require surgical management of a wound. Could be, for example, if someone has a really severe wound that just doesn't seem to be healing or on its own. There's sometimes we use like skin grafting. Maybe we have to go in and kind of maybe surgically close that wound, maybe do skin grafting to that wound, so that it can heal. Ideally, the wound will kind of heal and begin to build tissue, sort of from the inside out. And some of that is good healthy tissue. Also, scar tissue will develop, and scar tissue is not the same as what the normal tissue originally was. It doesn't have as much maybe elasticity as normal healthy tissue would have. It has a different appearance to it. It may not be as strong perhaps as the original tissue, but ideally as that wound heals, it will kind of heal from the inside out and look kind of normalish. I mean, I guess if you think of like maybe a time where you've gotten a cut on your finger, something very easy for you to perhaps visualize, and it's on your finger so you can see it. It may have been a pretty gaping cut for a finger, and it maybe bled a little bit, and you doctored it up and put some dressings on it, but ultimately it healed, and is as much as we use our hands as people, there's many times where you can't even tell that there was a wound there on that finger. So it's kind of healed from the inside out. So that's kind of the same sort of action I'm talking about, even with these greater wounds. Now, the more severe the wound, the harder it's going to be for that type of filling in of that wound bed, I guess. But that's what our goal is, and sometimes that just doesn't work. Sometimes we need a little bit of extra bump with a surgical intervention. As far as that concept of infection, we've talked about infection, right? We know that if there is an alteration in our immune system, with our skin being that physical barrier from the outside world, then we essentially have a portal, an open portal for the outside world to infiltrate that. And so just like with any infection, we are going to, do these things, monitor for signs and symptoms of infection. Does this tissue look infected? Is there and this is something where when we discussed infection, we talked about sometimes we can see with our eyeballs signs and symptoms of infection. Other times we don't necessarily see that. In a skin is oftentimes something that we can visualize, those signs and symptoms of that those physical manifestations, I guess, of infection. So you might see some purulent drainage or some redness or erythema, or swelling, all those things that perhaps you've seen before if you've had, some kind of wound that has gotten a little bit nasty looking. We do want to report any changes to the provider that might indicate that an infection is worsening or they're starting to show systemic signs of infection. Maybe the infection is spreading on your patient, and implement all of those interventions to keep the patient safe from infection or from worsening of infection. Go back to your basics here. This is those things like hand hygiene, using personal protective equipment, teaching patients about appropriate wound care and hygiene, things like that. So we did talk a little bit about some of the devices that we might use to help relieve pressure. So we're starting to move into some interventions for pressure reduction on those pressure prone places. And these are examples of some what we call waffles. And really, what they do is redistribute the pressure so that it's not all kind of pounding down on that one pressure prone place. So we have things like waffle cushions, waffle mattresses, waffle boots. When it comes to skincare world, there are millions of different types of products. The three that I chose to just kind of show you are things that you will find to be familiar in the clinical location where you guys are working. We utilize these products in our clinical sites, and so they just to know they may look a little bit different depending on perhaps where you decide to work or what have you. But basically, when we're talking about like a pressure relieving device, they can look a little bit different, but the point of them is to do the same thing. It's to redistribute that pressure across the body so that it's not all in that one pressure prone place. You can always, without a provider's order, at least in the acute care setting where I work, implement these types of interventions. So if you believe that your patient is at high risk for pressure ulcer development, maybe on their sacrum or their coccyx, or their ischium, their sits bones, and you're wanting to sit them up in a chair, you might choose to put a waffle cushion in their chair. Or if somebody is going to be in bed for long periods of time and they have very limited mobility, and you're concerned about pressure ulcers because they're in the bed, perhaps a waffle mattress is a good addition to your patient's bed. Same thing with the waffle boots. The nice thing about these little waffle boots is they have that little flap kind of under the heel there that allows you to what we call float the heel. And basically what's happening is that heel is suspended so that it's not resting on the surface, also known as the mattress. So it's providing that benefit there as well. There's also a variety of pressure relieving type dressings. I think these are Mepilex or Alavin. I don't know. Those are both brands. I'm not endorsing any one or the other. But basically, these are kind of cushiony foam. I think that's the generic term, foam dressings that we might place on a site that we're concerned about that it might develop into some kind of pressure ulcer. We can use these preventatively just to provide a little bit of extra pressure relief to that location. I've placed these on lots of bony prominences on patients, whether it be their sacrum or their elbow or their heel, or whatever the case may be, whatever area I'm concerned about. It is important to remember when we have a dressing in place, we are no longer able to visualize the skin underneath unless we remove that dressing for assessment. And so as nurses, it is your responsibility to do full assessments on your patients when you're caring for them. And part of that is going to be removing those dressings as appropriate so that you can assess the skin underneath of that dressing. We may have decided to place one of these dressings on someone's sacrum in the with the goal of no pressure ulcers developing. But if we never remove that dressing to assess the skin underneath, there could very well be a pressure ulcer developing, even though we've implemented this intervention as a means to prevent that. So we want to make sure that we are assessing our patient's skin underneath of these types of dressings, and not just merely saying that we couldn't assess the skin because the dressing was in place. We can move that and then either place it back if the adhesive is still good and the dressing is still viable, or get a new one and continue to protect that area that you're concerned about. Another thing that we do to help offload pressure points is the utilization of pillows. Pillows are kind of nice because they typically are well, they're available in abundance. We use pillows in the hospital, and probably in other healthcare settings quite routinely, and tend to have several of them at our disposal. Nothing special, nothing fancy. They're just pillows. And what we're doing is we are using pillows to keep areas that we're concerned about off of the bed, or off of relieving that contact, so offloading them. So we do need to be intentional when we're placing pillows. If the intention of the pillow placement is to offload or prevent that area from touching the surface for a prolonged period of time, then you have to remember that if you just place another surface, aka the pillow, under that pressure area, then it's not really offloading. We may use pillows for other reasons, though, right? I mean, if you've ever had like low back pain, for example, and you're trying to sleep in bed, sometimes we might say, let's put a pillow under the knees. It kind of relieves a little bit of pressure off the back, and that's fine. But the intention for that pillow placement under the knees to kind of catch the knees and relieve the pressure, the back pain, is very different from placing a pillow maybe behind someone's back so that it shifts the pressure off of the sacrum for pressure ulcers. So, we just have to keep that in mind. What's the intention of our pillow usage, and is the usage of the pillow meeting that intention by doing what it is that we're wanting it to do? And in this case, that is offloading. Um, turn your patients, or make sure that your patients are turning. Sometimes what happens is people don't feel well. They're very weak. Maybe they don't know that they need to turn. They have this conception that they're in the hospital and they're sick, and their only job is to just lay in bed and not move. I see that a lot. Other times, it hurts to move. And so, one pain management technique that patients will use is to avoid movement. But we know that when we're talking about skin health, we need to be moving the patient and taking pressure off of those pressure points so that we don't develop tissue integrity issues. Always, you'll hear this, always, always, always. If it's not documented, it's not been done. So when you are turning your patients, or assisting your patients to turn, or encouraging your patients to turn, when they move, we need to be documenting in our charting what position they have been turned to, whether they've been turned onto their left side or their right side, or whatever position you've placed your patient in. You need to document that, because if you don't document that change, then it appears to the person, or to anyone who's reviewing that charting, that the patient has stayed in the position for that whole period of time that no documentation has occurred. Now, hopefully, that's not the case. Hopefully, the patient has been moving, or you've been assisting the patient to move. But when we look at the documentation, it doesn't look that way. And so sometimes, unfortunately, that is the case. Sometimes patients are placed into a position and they remain in that position longer than what's recommended. Most sources that you'll look at least from what I could find, is turning patients for shifting pressure, relieving pressure. It's recommended like every 1 to 2 hours. Really don't want to let them lay in the same position for any longer than that. That's a good standard to go by, every 1 to 2 hours. We do want to make sure that we are keeping our skin healthy, and part of that is good skin care. Cleansing the skin is a good place to start. We don't want to use harsh chemicals, harsh soaps. So really just a mild soap with some warm water is sufficient. Hot water can lead to drying of the skin, which can ultimately lead to cracking in the skin and thus compromised skin integrity. So just remember that when you're working with your patients. Another thing also is as people get older, some pretty significant changes in the skin occur. We have a loss of elastin and collagen, which makes the skin less pliable, less flexible, and it doesn't kind of bounce back. It tends to become more fragile, also because we have a loss of subcutaneous tissue, which helps to support the skin. So this is why we can see things like tearing of the skin. So we just need to be aware of some of those changes. As we get older, our skin gets drier. We start to not produce as many oils in our skin. So we can help with that, not only by not using really hot water to dry out the skin, but also applying moisturizer to the skin helps to keep it soft and supple, so it's not getting dried out and cracked. But we do have to be careful that we're not like really massaging that moisturizer over bony prominences, especially bony prominences that are already at risk. Maybe they look a little red, or maybe a patient is leaning on their elbows a lot and it looks a little red there. So you want to be careful with that. Now when I say massage over bony prominences or areas of breakdown, really that's what I mean, like really rubbing for prolonged period of time over that area. I mean, we have to put moisturizer on that location. Of course, we have to rub over it, but we don't want to be massaging over it, if that makes any sense. We talked a little bit about protecting at-risk spots, whether that be through offloading and turning, or pressure relieving devices like those Waffle products, or some of those dressings that you saw pictures of. We also want to consider moisture barriers if that's an appropriate thing for our patient. And this is really to address that concern of like incontinence or diaphoresis, which is excessive sweating, or something like that. So some good recommendations just for some general skincare on our patient. Now, I handed out I don't know what you would call it, a stapled packet of papers, I guess you could say, that really breaks down the Braden scale. And the Braden scale is a standardized tool that is used I've always used it for as long as I can remember. It's always been the tool that I've used to determine what a patient's risk of skin breakdown is. We look at a variety of different things when it comes to, someone's risk for skin breakdown. So as you're reviewing that material, and we're going to work with this a little bit in class, so hopefully it will make sense to you, but we're looking at different known factors. Let me say this a little differently. Different factors that we know can contribute to skin breakdown. All right. So when we pay attention to those factors, those things that we know can lead to skin breakdown, and we identify um, what those factors are for our patient in particular, then we can implement individualized interventions to address that particular problem. So for each category, you rate the patient based upon kind of where they fall on that Braden scale. So the categories in the Braden scale are sensory perception. In other words, are they able to respond appropriately to discomfort that's related to pressure? So, is the patient able to feel their feet? right? Do they have paralysis? Can they move if they need to because they can feel that there's excessive pressure on a particular location? Another factor on the Braden scale is moisture. How often or how long is the skin exposed to moisture? Because the longer that the skin is intact, is in contact with moisture, the more likely it is to develop breakdown. Another category on the Braden scale is activity, like how active is this patient? Are they bedridden? Are they confined to a chair? Do they get up and mobilize? Maybe a little bit. Maybe they walk to the bathroom a couple of times a day. Or do they walk really frequently? When someone has increased mobility, then it stands to reason that they are able to reduce pressure on those points, as opposed to someone who is maybe completely bedridden and not able to mobilize whatsoever. One thing that I want to say about mobility is that's very specific to the condition that the patient is currently in. So, for example, if you have a youngish patient who's maybe like 34, and when they are at home, they are playing basketball and they're, running around town and they're driving and they're, cooking and cleaning and going out and doing all of these activities. Then, of course, they would be in that highest level where they're very active, very mobile, they walk frequently. But if you take that same person that normally is very active and they become incredibly ill, and perhaps they end up in a very critical, like maybe they end up in critical care and they are not moving whatsoever independently, maybe because of medication or severity of their illness, just because they used to get up and walk around doesn't mean that they are walking frequently, right? So it really is specific to the condition that they're in that moment when you're assessing the patient. So if that patient, for example, were in critical care and they were very, very ill and they were not able to move, not be active really at all, then they might be very much lower on that Braden scale, maybe rated as a 1 as opposed to a 4. Activity kind of goes hand in hand with mobility. Mobility really refers to the patient's ability to be able to not only change positions, but also control their body position. So sometimes patients might be bedfast, right, as an activity, but they may still be able to have a little bit of bed mobility. Maybe they can turn themselves in bed or they can make shifts and adjustments in bed. So, two different categories. I just want to kind of provide a little differentiation between the two. So, what's the patient's physical activity level compared to how are they able to change their position? How mobile are they in terms of being able to change the position and make those adjustments to their pressure? So someone doesn't have to walk frequently to be able to have decent or very good mobility just because they're in bed. Nutrition, of course, is another factor. I've mentioned that a couple of times already. We want to look at what their usual food intake is. How much of their food are they eating? Do they eat just very little amounts? Do they eat, adequate amounts of food? Are they getting adequate amounts of protein? Are they getting adequate amounts of hydration with fluid intake? Or are they not? Sometimes it's the diet that's been ordered for the patient for whatever illness they have may not necessarily be of their choice, but perhaps the patient is on a tube feeding. They may be inadequate with their nutrition. Now, not always. Tube feeding does not equal inadequate nutrition. It could be adequate. It just depends on, what the caloric needs of the patient are and what we're providing to them through that particular type of nutrition. And then friction and shearing, that's the last category on the Braden scale. And this has to do with how they move. Are they able to move? Really, what we're talking about is in the bed or in a chair or something like that. Are they able to move so that they can lift their body part up off the bed so that it doesn't cause friction and shearing, as opposed to sliding and scooting? So, for example, when we assist patients to maybe move up in the bed, it's ideal that we provide a little bit of lift and then pull up, as opposed just to a slide up in the bed. Because when we slide a patient up in the bed, whatever is touching the bed is going to be prone to that friction. In other words, like their skin is going to move over and in the opposite direction of the underlying tissues and over the bed sheets, that could cause some breakdown. So that's kind of the basics of the Braden scale. We assess our patients using the Braden scale every shift or more frequently. And what we do with that Braden scale is directly related to what we have found on our Braden scale assessment. So if we look at those categories on the Braden scale and we identify that the patient, I don't know, maybe they're immobile, or excuse me, their activity level is maybe their chair fast, but their mobility is only slightly limited, then our interventions really need to be working towards their activity level, as opposed to maybe their mobility in that position changing kind of way. Or if they have really good oral intake with adequate nutrition, but they're incontinent, then our focus should really be looking more at moisture control, as opposed to perhaps focus quite so much on nutritional interventions. So that's how the Braden scale really can help us to consider what we need to be doing for our specific patients based on that assessment. Makes it a little bit more individualized. Now, one thing that we discussed was device-related pressure ulcers, and that doesn't really have anything to do with the Braden scale, but it is something that we have to consider because it's an area of tissue that's going to have prolonged contact, and in this case, a device. So any type of medical device could lead to a pressure ulcer, or any type of device really. But we see a lot of different medical devices in our care of patients that can lead to prolonged contact of the skin because of those devices. It can lead to breakdown of that tissue. In the next few slides, we're going to see a few patients here that have some particular risks for pressure ulcers based on Braden scale and things like that. Maybe pressure devices. And so we're going to talk about these together in class, and perhaps as you're reviewing these independently, maybe you're listening to this lecture again just to get a little bit more clarification. Just kind of think about the Braden scale and those device related risk factors and what that is going to mean in terms of your interventions for the patient. So for example, this gentleman with a history of COPD that wears 2 liters of oxygen per nasal cannula right off the bat, one thing that I am concerned about is that device potential for pressure ulcer, not only in the nares, but also potentially behind his ears. And so as the nurse, I am going to be assessing this patient behind his ears routinely to make sure that there is no evidence of pressure developing there. So looking for things like redness and that kind of thing. Another thing that I am concerned about with this patient is the fact that he's doing what we call tripoding. You see how he's kind of leaning forward so that he can expand the area in which his chest can expand and take in volume so he can oxygenate, ventilate better. One thing that often happens is you get tired, right? I mean, imagine sitting like this with your hands on your thighs. His hands are there kind of on his thighs, his knees. And so you might find this patient kind of leaning on their elbows on a table. And so that will put those elbows at risk for a pressure ulcer. Another thing that I'm seeing here that I'm very concerned about is the fact that he has trouble with hygiene because he gets very short of breath. And so I want to make sure that I'm, doing things to implement good skincare to help reduce that particular risk. There could be some concerns about incontinence if he's having a difficult time making it maybe to the bathroom, and because he is short of breath. I also noticed that he's lost 10 pounds in the last month and it wasn't intentional. Probably, if I had to guess, because he can't eat. And that's supposed to say does not eat. It's not supposed to say does not eat. That's a typo. Because it's too hard to eat because he can't breathe, right? Breathing, eating, which means that he's going to probably have more bony prominences, maybe on his sacrum, which he's sitting likely a lot because it makes him short of breath to walk. So I'm going to be assessing his sacrum routinely to make sure that there's no breakdown noted there. With that much weight loss, we could start to see maybe the spinous processes become more visible, or the scapula, perhaps losing some of that subcutaneous tissue. So those are the kinds of things that I'm thinking about when I'm walking into a room and I'm seeing a patient such as this, with this type of information, and how I'm using that information to figure out the locations that are at risk, but also the underlying kind of things that are going on with the way that he's sitting and the tripoding and the elbows and things like that. So think about those things as you look through these patients, and you're reviewing this, like what is this going to look like in my patient? What am I going to be concerned about? And then how would I intervene? And part of it is just routine assessment. Other things might be maybe I put a foam dressing on the sacrum. Maybe I put foam dressings on the elbow. Maybe I talk to a dietitian about appropriate nutrition. Maybe I talk to the patient about balancing his rest with activity. Maybe I find the patient foods that are easy to eat and don't require a lot of like cutting and stuff like that. So lots of different ways that we can intervene for patients simply based upon what it is that we're seeing. This is a good example of a patient who has a lot of different devices, and this is a young person. Normally, young people, we think of them, as having good health, maybe very active. But in this instance, this patient obviously is in bed, and so his activity level is very limited. It looks like he is on a ventilator, so he's probably sedated, so he's, very limited mobility here. There's probably some alteration in his nutrition. It's kind of hard to tell, back there what kind of nutrition he's getting, if any. I think I see an OG too, but I can't tell if there's feedings back there. So I'm concerned about nutritional interventions. And then I have some devices here that I'm concerned about too. There's the endotracheal tube is kind of tugging there on the lip. There's all that tape that's kind of across the face that can lead to tissue damage as that is maybe taken off. I've got a blood pressure cuff that's on the arm. That could be a place for a device related ulcer to develop. I need to be assessing that routinely. The place where the tubing that comes off that leads to the ventilator is kind of lying on the chest there. So lots of different places that I'm assessing routinely, and repositioning tubes and things like that to avoid tissue breakdown. If the patient has STDs in place, these too can be a culprit for the development of device-related pressure ulcers. So I want to make sure I'm taking these off, that I'm actually thoroughly assessing the skin underneath to be sure that the patient's not developing any problems there. So I'm not going to go through all of these things with every single one of these patients in these slides for this recorded lecture, but things to think about as you're working through this and thinking about the Braden scale and how we could intervene as the nurse. This one's very different. This is a patient who has a lot of excessive body tissue. There could be some mobility here. It says the patient is bedbound. There's definitely a moisture issue going on if the patient is incontinent. So how can we intervene with this patient? What are things that we need to do? Just aside from the obvious, obviously this patient has a significant wound that we need to be treating, but how can we keep that from getting worse, and how can we prevent new wounds from developing in our patient? This one's a little bit different than the patients that we've seen, simply because this patient is prone. In other words, they're lying on their belly. So we have some very different areas that we're concerned for pressure ulcers, like the side of the face. Normally, when someone is lying on their back, we aren't concerned about pressure ulcer on the side of their face, or maybe their knees, because that is coming into contact with the bed, or maybe the tips of their toes. So again, we have to take into consideration the particular patient that we're taking care of and what we see. You guys did a really good education on pressure ulcers with NDNQI. Went into some great depth there. So I'm just going to sort of highlight some of the key things, the key takeaways from each of the stages of your pressure injuries. How can you identify the pressure injury? Well, stage 1 pressure injury is completely intact. There's no opening in a stage 1 pressure injury. What we're seeing is what you see bolded here, and that's a non-blanchable erythema, often redness. And so what that means is if I were to take my finger and kind of press down on that reddened skin, it would stay red. If that happens, that's a stage 1 pressure injury. If you first identify a stage 1 pressure injury, or think that's what you're dealing with, one of the best things you can do is offload that area of pressure, so that you can allow for return of blood flow and circulation to that tissue. Come back in an hour and reassess. If at that point it still remains a non-blanchable area of redness, then you really need to start implementing your interventions hardcore. Turning, offloading, pressure relieving devices, good hygiene, getting rid of any moisture control issues, working on activity, mobility, all of those types of things. Now, if you come back after that hour and it does blanch, meaning it does turn white when you, press down that tissue, then it's not really a stage 1 pressure injury, but you have now identified an area that is at high risk for the development of a pressure injury, and you still need to implement all of those interventions from preventing that into turning into a stage 1 pressure injury. Stage 2 pressure injuries are identified by a partial loss of skin. So we're going to see some exposure of the dermis. The wound bed, you do have to be able to see that, but usually it's going to be pretty shallow when you're dealing with a stage 2 pressure injury. A serum-filled blister is an example of a stage 2 pressure injury, and whether that blister is intact or that blister has ruptured, that epidermis is compromised, and so we are dealing with exposed dermis, and that is then a stage 2 pressure injury. Stage 3 pressure injuries is when we start to see fat or adipose tissue within the ulcer. That's how we know when we're dealing with a stage 3 injury. We can also start to see some other things, but they don't necessarily define the fact that it's a stage 3. So once a pressure injury gets to this point, we could start to see what's called undermining or tunneling. The way I like to think of undermining is when I've been hiking and there's big rock walls kind of, up along both of my sides, and I look up and the rock wall kind of like cliffs out over me and it kind of has that little overhang. That's what's happening with undermining. There's this area of tissue underneath the skin that has kind of worn away and the skin kind of overhangs the wound. Now, tunneling then would be like in that same hiking expedition, I have now encountered a little cave, and there is essentially a tunnel that runs underneath the skin for a period of time. So, like a little bit of a cave. So that's what those two terms are referring to. We might see something called slough or eschar. Basically, this is non-viable tissue. It can obscure the wound bed, making it difficult to actually stage a pressure injury. And because it's non-viable tissue, it can also impede the growth of good, healthy tissue that we want to see, like granulation tissue and that sort of thing, in the wound bed. And so those types of things that you would see, slough and eschar, those have to be removed so that that wound can begin to heal effectively. Stage 4 pressure injuries is when we start to see those deeper structures, whether it's fascia, and remember that's that fibrous connective tissue that kind of encapsulates all of our muscles. We might see muscle, tendon, maybe even all the way down to the bone. Again, these can have non-viable tissue kind of obscuring the bed of the wound. So if that's the case, we have to get rid of that tissue through some sort of debridement mechanism to be able to stage the pressure injury appropriately. And we may even see, just like with the stage 3, we could see undermining or tunneling. So again, undermining and tunneling don't define a stage, rather they're just things that can occur or that you may see on your assessment with a stage 3 or a stage 4 pressure injury. A wound is unstageable if you cannot see the wound bed. So, for example, this top picture shows a wound that has eschar or dead, non-viable tissue that's kind of hard and leathery over the bed of the wound. So I don't know what I'm looking. I don't know if there's adipose tissue under there. I don't know if there's muscle or bone. I don't know until that eschar is removed. So some sort of debridement is going to be required before that can actually be staged, and until that happens, it is unstageable. A suspected deep tissue injury occurs because of prolonged contact to that tissue. It could be maybe someone was lying on the floor for a long period of time in one position, or even maybe somebody was left on a bedpan for a prolonged period of time. But it's caused the deep underlying tissue to become damaged, but the external portion, the skin, still appears to be intact. Oftentimes it's a different color than the surrounding tissue, often maroonish or a darker color than the surrounding tissue. And when you palpate it gently, of course, it may even feel what's called boggy or kind of mushy, kind of like if you drop an apple on the floor and the apple, like the part that's good to eat, is kind of mushy, but the skin is still intact and sort of discolored. That's what I kind of think of when I think of a deep tissue injury. Blood blisters are actually considered to be a deep tissue injury as well. So instead of serum filled blister, right, with that stage 2, with a blood blister, you'd have that raised area of skin with blood that kind of fills it. All right, so that was our discussion on pressure ulcer staging, how we identify who's at risk for pressure ulcers, and what kind of interventions we implement um, because of our known, risk factors and contributing factors for the development of pressure ulcers. Cellulitis, just real quick, this is an infection in the skin that actually extends down into the fatty tissue underneath of it. It can be very mild, it can be very severe, but for some reason, there has been a break in the skin, and this has allowed bacteria from the external environment to then get into that opening and cause cellular damage and infection. Um, Patients who have who are prone for having breaks in the skin, whether that just be because of poor skin care or maybe really dry skin, something like that. Uh, Maybe they have a pressure ulcer. That would be a break in the skin. They could develop cellulitis around that. If they have a weakened immune system, normally, we get lots of cuts and bumps and bruises. Oliver really likes to play rough, and I've got all these little scratches and stuff. I have not developed cellulitis because my immune system is healthy, and is able to recognize that potential invasion there, and so I've not developed cellulitis. As of yet, thank goodness. But if someone were to say maybe have a weakened immune system, then playing with Oliver the way that he likes to play may not be the best for them. They'd be at risk for developing maybe some cellulitis. DM, that's diabetes mellitus. And then individuals who are IV drug users, they're making punctures in the skin, and so it's that opening and potential for bacteria to enter through that opening. We want to clean it. If there is some kind of area that we can identify as open, we might cover that. Now, if I look at this person here on this slide, I don't think I'm going to put a big bandage or anything on their face. Probably more than anything, just keep it clean, and it's going to be painful. I would think it looks swollen, so provide pain interventions for the patient. It's an infection, so they're probably going to need some antibiotics of some sort, teaching them about like good hand hygiene, not to be touching it, and what have you, as they're healing and getting better. It can spread pretty quickly, so it's not something to just kind of scoff at. If it's bad enough that your patient's requiring antibiotics and seeking care for it, we do need to be aware of worsening signs and symptoms of infection. As it starts to spread, we're going to see those systemic signs of infection that we talked about before, maybe fever or leukocytosis or tachycardia, hypotension, all of those different things that we might see as a patient gets really sick and becomes septic. All right, arterial ulcers. This would be like in relation to like peripheral artery disease. So when we think about arteries, the thing we have to consider is that arteries take blood to tissue, right? That's what arteries do. And so when we develop arterial ulcers, it's typically because blood flow has not been able to get to that tissue, which is problematic. When we don't get blood flow to a tissue, then we don't get oxygen or nutrients or anything else to that tissue. And so if there's any type of injury to that tissue, then that tissue doesn't have what it needs to be healthy, right? Some of the risk factors for arterial ulcers, you can see here, there are others. I think these were the highlights. Arterial and vascular ulcers in your book was kind of scattered. I think I made some references to pages in our weekly overview, but more than that, there's a reference for you that's posted on our Canvas page that kind of outlines arterial and venous ulcers kind of side by side with risk factors and comorbidities and all of those different things. Do take note that it also talks about diabetic ulcers. We are not covering diabetic ulcers. So that last column on that reference that I've provided for you, again, we are not talking about, diabetic ulcers. So that's not something that I want you to be spending time on looking at. We're focusing on arterial and vascular ulcers. So as I mentioned, it's an issue of blood not getting to that area effectively. Very common that we see arterial ulcers in the lower extremities if they have arterial issues. But we can also see other manifestations of poor flow of blood to the area. Things like hair loss on that extremity. Legs are, normally are supposed to grow hair on them. So if you have like a complete absence of hair, that could be a sign of arterial insufficiency, which means that your patient, if they sustain some sort of wound, they could develop an arterial ulcer because of that. We can also see some other skin changes, like with the way that the skin looks. If I don't get blood flow to the extremity, then that extremity is going to be very pale or discolored, maybe kind of like a purplish. I don't want to be like purple, like Barney purple, but mottled. Google mottled. I wonder what you'll come up with there. Kind of like a bluish purple, scattered bruising, but not really like a bruise. Look, Google it and see what happens there. It's just a weird pale, bruisey discoloration to the skin. Another thing to consider is blood also provides warmth to our skin. And so if I'm not getting good blood flow to the extremity, then I might have some coolness to that to that extremity. Pallor may occur when the extremity is elevated. So when you elevate the extremity, then whatever blood flow is in that leg has made it to that extremity. Since there's not a lot, then the leg could get really white. Dependent rubor means that when my legs are in a dependent position or below, they're hanging down or dangling, they can get really red and purpley color. That's what dependent rubor is. So overall, what we're seeing here that kind of can accompany and help us determine what we're looking at as arterial are those signs of poor perfusion because of the blood not getting to that extremity effectively. Location can also help us figure out that it is an arterial ulcer. They very commonly occur on the lower extremities, especially the toes. The medial malleolus, that's like the inside of the ankle there, and they tend to have a certain type of appearance, very well defined borders. Sometimes they can have a very punched out looking appearance, like someone took a hole punch and just punched it out. They tend not to have a lot of drainage because remember, there's not a lot of blood flow to that area, so we're not going to see a lot of drainage associated with them. On this foot in the middle, you can kind of see how ruberous that extremity is. You've got those ulcers kind of on the top of the toe, and how red and kind of reddish purpley that color of that leg is. Same with the leg there on the left, kind of how ruberous, how reddish that looks. And none of these are really draining a whole lot, and just that location can kind of tells me what type of that this is highly likely that it's a arterial ulcer. So what can we do to help heal arterial ulcers? Well, we need to get perfusion to that tissue, because the reason that those wounds are not healing is because we're not getting perfusion down there. Exercise and positioning can be helpful. So maybe we want the patient to be in a dependent, like dangling position with their legs to help promote blood flow down there. How can we promote vasodilation in that extremity? Sometimes this requires surgical intervention, such as revascularization. In other words, they go in and they kind of pop open the vessel. Sometimes they have to bypass a vessel that's very diseased so that we can get blood flow to that location. Patients might be on antiplatelet type medications like Plavix, that's also known as clopidogrel, so that blood kind of flows through the narrowed space a little bit easier, and they can get some blood flow there. But ultimately, if it's really bad, we may have to do, like I said, arterial revascularization, so that we, get blood flow to that extremity. In very severe cases, amputation might be required, whether that's amputation of a digit or of a, like a whole leg sometimes, if it's really bad. We want to prevent infection in these patients. Now, not all arterial wounds are infected, but we do want to do our best to prevent infection by providing good wound care and, monitoring for signs and symptoms of infection and things like that, and then manage pain. Sometimes these arterial ulcers can be very painful for our patients, so we want to manage that. Now, venous ulcers, they're a little bit different. They're going to have some very different characteristics associated with them. Again, you can see a list of risk factors that are common here in patients who may develop venous ulcers, and you'll find a huge long list of these in that reference material that I provided for you on our Canvas page. But yeah, I'm not going to read this whole slide to you. But ultimately, what's happening with these venous stasis ulcers is, remember, veins return blood back to the heart. And so with venous stasis ulcer, blood is not able to leave the tissue. So it just sits there, and it starts to kind of cause irritation to the vessel, breakdown of the vessel and tissues. And we start to have development of wounds, really. Those muscles, that are in our legs, we want them to help us move the blood back up to the central circulation. We want to promote the return of blood from the periphery back up to the central circulation. And, that's kind of our goal in our treatment for a patient who has these venous stasis ulcers. Now, they look very different, as you'll notice, than the arterial ulcers. They still commonly occur in the lower extremity, but you see some different color changes. This brownish discoloration that you can see really on all of these, as I look a little bit more closely, that one kind of in the top middle there, it looks a little ruberous, but we could probably go with vascular. But that brownish discoloration that you're seeing has to do with that like the damage that's occurring because of that blood kind of staying in those vessels when it needs to go away and back up to the central circulation. It causes this they're called melanocytes, an excessive deposit of melanocytes, and so it causes that discoloration. Very common thing that you will see. Now, it's not a problem of blood flow getting to the area, and oftentimes, because of that reason, these wounds will be very highly exudative, meaning they have lots of drainage. And so the peri-wound, or that area that's around the actual wound, can become what's called macerated. You ever had a band-aid on your finger and then gone swimming, and then you take your band-aid off, and that tissue underneath the finger was like all wrinkly and swollen and white? That's what I always think of when I think of macerated, because it's that prolonged exposure to that water, right? That moisture. Well, when we have a highly exudative wound like a venous stasis ulcer, that can happen to that peri-wound. And that's part of our care and treatment of these patients, is making sure that the peri-wound can stay nice and dry. So that we don't get that maceration and breakdown of that tissue. Here on the ankle, you can see kind of that looks like a medial ankle. And then on the lower extremities, and you'll notice the shape of these is very different. The borders are very irregular here, and they're accompanied by that characteristic discoloration. So remember, the arterial ulcers were very well defined and kind of punched out, as opposed to these vascular ulcers. They look a little bit more regular. They have that characteristic color discoloration around them. They seem to be a lot more extensive, don't they? Much larger. And these look pretty cleaned up actually, but they're very highly exudative. So part of our treatment, like I mentioned, is managing that exudate, protecting that peri wound so it doesn't become broken down even more, and promoting venous return. So these are the patients where maybe we need to elevate their extremities to help with that management of that blood flow that's not able to get back up to the central circulation independently. Um, Maybe they require some kind of compression dressing. Now, those wounds on that right there, it'd be very hard to put, like, you couldn't put SCDs on those patients, and I don't even think, especially those four legs on the bottom, you would want to put like a Ted Hoser compression stocking on. But maybe the patient that's kind of that upper right hand picture, that patient clearly has vascular um, disease. That patient, I might recommend that they wear pressure stockings to help promote venous return so that they don't even develop a venous stasis ulcer, fingers crossed. So those are the types of things that we're using to promote venous return. There are certain types of pressure type dressings that we can utilize in the management of that particular wound, where it can help with like absorption of all of that drainage and also provide compression. So if you're ever in the clinical setting and you see someone who has like a dressing that's wrapped from basically their toes all the way up to their knee or beyond, that's probably for treatment of some type of venous ulcer, and that pressure from that wrap on that leg is trying to promote that venous return. So that is the end of our discussion on tissue integrity at this time. I guess if you have questions, please reach out and let me know if I can help you clarify anything with tissue integrity. Otherwise, I guess that'll do it.